It should be in each visit that we do not know. Intermediate risk should be individualized because again we do not know the first schedule for the intermediate other than the NCCN guidelines. They had other guidelines don't support those schedule. If we certify the highest risk NMIBC, maybe it will affect the cost and the follow-up schedule. And the biomarker may replace the scope in the future, but it needs more validation at present. Now coming to the cystectomy, condi or the neobladder, that generally focuses on the local distant recurrence, the upper tract effect, either recurrence in the upper tract or the functional outcome, metabolic and functional issue with the neobladder and the condio. What we should focus on again in this aspect is the rehabilitation, which I think Dr. Gagan, Dr. Amandi will be agree that this improves the quality of life. And all the guidelines, again, have the same protocol with the 3 to 6 month year imaging for the 2 year, and every year they should have a LFT and the biochemical and the blood test investigations. This article specifically compared the detection rate with the NCS guidelines and the EO guidelines. And if you can see, EO guidelines has 20% more detection rate compared to the NCS guidelines. And they quoted that the patient older than 80 years with T0NX disease, which would not die with the cancer mortality, compared to the age of 60 years of the patient who is having T4 or T3 disease, he should have more stringent follow criteria compared to the 80-year-old patient. It should be the same for all the patient. So what they propose that a surveillance algorithm based on the interaction between the recurrence rate and the competing health factor should be utilized when proposing a follow-up for these patients. Again, the topic on the optimal delivery follow-up care, as Amandeep said, it takes at least 1 to 2 years to see the rehab of the patient after the cystectomy, along with the recurrence other things, which include physical training, nutrition supplement, and patient education of stoma care or the neobladder care, and it has a level 1 and level 3 evidence to support this care for these patients. This article specifically stratified the MIBC patient in low risk, intermediate, and high risk patient, and they give a scoring system based on cardiovascular disease, peripheral CKD, type of diversion, and TNN, presence of LVI. And when they divide it into the low risk, if you can see, the follow-up schedule is just like a MIBC, maybe the low grade intermediate risk of the patient. High risk, however, is similar to what are proposed in the guidelines. And they propose that risk score stratified surveillance protocol has potential. It is not proven, but has potential to reduce over-evaluation after cystectomy without adverse effect of the medical cost. So what my take on that, EUA protocol has a better recurrence detection rate compared to the NCS guideline. Age at treatment can be used to determine the frequency of follow-up. Initial 2 years are very critical to assess recurrence and the functional improvement. After 2 years, it can be individualized based on the patient factor and the disease factor. And sub-certification may help reducing follow-up schedule without affecting cancer care at the individual basis. Coming to trimodal therapy, which focuses on local distal recurrence and the upper tract, definitely metabolic complication is not with the trimodal therapy. And the follow-up is almost similar with the MIBC patient, other than cystoscopy every 3 months, 6 months, and annually. And the clinically indicated, as well as the imaging as per the guidelines. This article from the Tata Hospital proposed that if we do cystoscopy, either every visit 3 monthly, or every 6 monthly, or when there is a doubt of recurrence in the bladder, and they found that there is 64 and 67% finding rate if we do either alternative 6 monthly or when doubt is of the recurrence. And they propose that it may replace the imaging follow-up for the post-trimodal therapy. But again, we do not have very much evidence on the trimodal therapy, how to follow up other than the guidelines and how to modify it. But I think that MIBC protocol should be followed over there, and cystoscopy along with the CT scan or other imaging may be detected the better cancer detection rate compared to the only scopy alone. This article generally focuses to find out the cost of the follow-up patient with the cystectomy as well as trimodal therapy, and they found that the outpatient visits post-operative period are the main factor which are affecting the patient and increasing the cost for the patient. Future, The Eurofollow trial will tell us something about the less intense follow-up, but again, it is focusing on the low grade, not on the high grade and the intermediate risk that we do not know how it's going to help us in future. So if we again think and see the hurdles in India factors, so I would like to just conclude. This is not take-home message. This is just a suggestions about that. For NMIBC, individual adaptive approach may reduce number of follow-up cystoscopies. For MIBC, initial 2 years are critical for oncological, functional, and metabolic assessment. Risk system may help to define better surveillance strategies. For TMT, MIBC protocol plus the cross-section imaging may improve the detection rate, frequency that we had to define. And assessment of cost-benefit ratio for the patient point of view should not be ignored. Follow will guide us, but for low risk, we don't know how it's going to affect. But not, we should have urgent need study focusing on optimizing surveillance protocol in our India, keeping patient factor to reduce the health resources and the patient burden in our country. Thank you.
We have 5 minutes for discussion.
Thank you, Dr. Mahendrapal. So most of us are following the Western guidelines. So whatever they say that 3 monthly, we told patient to come after 3 monthly, but our patient is very different. So they has to travel a lot, and we need to consider the economical factor and their social background. So you told us that this intermediate risk is individualized. Can you highlight some of the points? So whether they go into the low risk category and infrequently cystoscopies, or they go into the high risk? What are those factors?
So by definition, we do not have exact factors for the intermediate risk. Yes, it's about low risk. It is a TAG1 is a low risk. High risk, T1, NEG3, CIS is the high risk. But what comes in this intermediate risk, even we do not know. If you ask me that this patient in category, I will take 30 seconds to think about which category it is, right? So again, we should know, and about the follow-up schedule, it also be individualized. Maybe for low risk, it is 3 monthly, 9 months, and annually. And for high risk, it is a 3 monthly for 2 years. It may be 4 monthly for 1 year, maybe like that. Even we don't have guidelines, but we can individualize at the patient basis. Where does he stay? Like that, he's coming from bus, from the train. What his profession is, whether he's able to bear the cost of the follow-up. Everything we have to think about before putting in intense follow-up for the intermediate risk.
Mahendra.
Yes, sir.
Here. In trimodality treatment, after trimodal treatment, you said imaging and cystoscopy. Now, recently what I have seen, because many patients, they do get trimodality because cystectomy everybody avoids. The patient is followed by PET scan. And PET scan does show the uptake in the bladder, and you do the cystoscopy, there is nothing. Probably you can resect that area,
yes,
and there may be nothing. So what is your take on, or maybe other like in crowd who are doing trimodality, what is they have their experience? But my apprehension is always that if the patient fails, because of that uptake in the PET scan, he actually can, come back to you and saying that you did not diagnose or what happened. So what is your this?
Yeah, so sir, in this case, when the PET scan is done after the radiation therapy, either it is within 3 months, within 6 months, or within a year, and urine cytology report, if it is negative or it is positive, I think these two factors will decide to do scoping or the biopsy or not. But if there is a persistent, and maybe we can also follow up after 2 months of the PET scan. If it is still avid area is there, then we should have a biopsy, because we do not know it is a disease or just inflammation. It should be individualized. There are no guidelines about even PET scan is not recommended. I don't know why it has been done also. Yeah.
See, I'd just like to share my personal experience. I have my follow-up of my treated own patients, both groups, for 15 to 20 years. So first 2 years are very crucial.
Yes.
In that period, we follow what you said. After that, it is individualized.
Yes.
That is my practice, and that is I'm doing.
Thank you very much. I just wanted to emphasize in the post-cystectomy one, there are the 3 things: upper tract deterioration. For whatever reason, in Christie Hospital, we used to do a MAC3 renogram for every year for these patients. And what we picked up was 30% of post-cystectomy, ileal conduit, would have a deterioration in the renal function, out of which 30%. So overall 10% would have an obstructive cause. So always consider doing a DTP renogram or a MAC3 renogram for upper tract assessment. That's one. Second, for the urethral recurrence, we used to do a flexible urethroscopy, but that we replaced with just saline barbotage of the urethra, and we know that that's good enough. And which ones you do more intently depends on your pathology element of it. And then the third aspect with respect to the recurrence of the primary, there would be the systemic recurrence and local recurrence. And with all the adjuvant treatments we are doing, especially RT, the local recurrences we can control, but the systemic will be with the CT or a PET CT scan, depending on whatever patient can afford. Thank you.
Right, sir.
Mahendra, I had one comment. What about this flexi-cystoscopy? Is it overdone? We are talking about it more often than required, or it's not the answer actually?
Sir, if it done as per the schedule, so it is just a method to see the bladder for the patient comfort level. But I don't think so. Nobody is using monthly basis or something like that. It is just like as per schedule, it's a comfort level of the patient, and it's proposed like it's a more comfortable for the patient.
They say it's an office procedure.
Yeah.
I mean, that's the problem sometimes. If you find there is a tumor, then you have to take to the OR.
Right, sir.
Yeah, that's the problem.
Basically, most of the European studies also what they've done is previously they used to do sort of bar test or cytologies to find out if it's positive, but they are scheduled for a flexible cystoscopy outpatients. There is a parallel theater which is available. In case if you find, then you put it to sleep and do it. No.
Sir, I think only biopsy they do in the day procedure, not the TURBT.
No, we keep this theater standby ready. If you have found out, then do it. So it
Agree.
saves the visit.
Yeah.
Thank you, Dr. Mahendra Pal.
Thank you.
And I would now like to invite Dr. Amit Rautan, who's a consultant medical oncologist from Manipal Hospital, Bangalore, to talk upon upper act urinary cancer for adjuvant versus non-adjuvant therapy. Over to you, sir. You've got 9 + 6 minutes.
Thank you. Good morning, everyone. So my topic is upper tract urethral cancer, adjuvant versus neoadjuvant therapy. So we know the challenges we face in the upper tract urothelial cancers. It's a rare disease, seen quite uncommonly compared to urothelial cancers. If you compare stage by stage, the prognosis is definitely poorer than the urothelial cancers. We face the major problem. The exact staging is something we always differ about. We're never sure about what we are dealing with. Is this the exact stage? Because we're never able to get muzzle in the biopsy. And so that's quite a times we treat these patients even with cytology reports saying that if you have a high-grade tumor, they're high-stage disease. So this is always a problem which we face in upper urothelial tract cancers. There's always the major issue we talk about, renal dysfunction, which will set in after surgery. And we've seen various studies showing various declines in renal function. And again, a small population, so data is small. Whenever you have smaller data, you're never sure what you're telling your patients. You cannot tell them emphatically that this is the results. And you always kind of put it, this could be the positives and this could be the negatives, and then you take a decision. And that's what happens in clinical practice. So I will do the same as what we do. I will tell you the positives and negatives, and all of us can take the conclusion the way we want to. So if it's adjuvant chemotherapy, the advantage, clearly, you've done a surgery, you know the exact stage, you know what you are treating. You know you're going to treat only your high-risk patients, your low-risk patients you may get away without giving them and exposing them to any chemotherapy. And the best thing is you have a robust data. You have a big phase 3 trial, which is amazing to see, which was done in this rare indication. The major disadvantage, we've seen, you remove the kidney and you do a nephrourectomy, you're definitely decreasing the GFR. There have been studies which said that it came down from 58% to 15%, the eligibility for a cisplatin-based regime in various studies. Again, this is kind of an overkill, I think. It doesn't happen that much, but definitely there's a decline in GFR, and we know that cisplatin eligibility may change. I think this is one of the most elegant studies in this setting, the POUT study. It was a perioperative chemotherapy versus surveillance in upper tract urothelial cancers. Now, this study was done over in the UK. They looked at patients who were upper tract, who operated. They looked at PT2 to PT4 or node-positive patients. So they said these are the high-risk patients who need adjuvant chemotherapy. Before this, the standard of care was surgery followed by surveillance. So they randomized surveillance versus chemotherapy. And the chemotherapy used was gem-cis or patients with gem-carbo. Now here was the inclusion. They actually reduced the GFR to 50. So we in practice say 60 is our cutoff for cisplatins, but they said we can even go down to 50, which is good, which enables more patients to get cisplatin. And they said you could sometimes, if you're not sure of it, you can even do split cisplatin dosing, which we do in practice quite a lot. But if it was below 50, between 30 to 50, they said we could use carboplatin, and gem-carbo was the regime. 4 cycles adjuvant. Primary endpoint, disease-free survival. Secondary endpoint, metastasis-free survival and overall survival and quality of life. A clear improvement in disease-free survival. I think there's no denying the fact, if you look at that 3-year mark, 50% versus 71%, hazards of 0.51, there's absolutely no denying there's clear benefit in disease-free survival by doing adjuvant chemotherapy of 4 cycles versus surveillance alone. Metastasis-free survival, again, a very clear benefit, hazards of 0.52. Which subgroups benefit? And this is important. And what we saw eventually, every subgroup benefits. So clearly, there's every patient benefiting when you're doing adjuvant chemotherapy in this subgroup, in this population. The right side curves are overall survival. They are numerically better. They didn't cross statistical significance, but then again, that was not the primary endpoint. So clearly the conclusion, adjuvant chemotherapy, gem-cis, rarely gem-carbo, is the standard of care for patients who have been operated with more than PT2 disease. But we could do neoadjuvant, and bladder we have moved to neoadjuvant, and we extrapolate the same data and we say we do neoadjuvant in urothelial bladders, why don't we do it for upper tract cancers? Advantage, clearly the kidney is there, the creatinine is good, the GFR is good, you can give them the ideal cisplatin dose. You're not going to compromise on anything, you're not going to start talking of carboplatin, which we all know in our minds is not great, but we do it because we can't do the cisplatin. We can see our responses, and we can, after we give the cisplatin-based chemo and when you operate and we look at PAT-CR, we can tell patients, we can prognostify them. There's a subgroup who will do well and the survivals are good, or there's a group who did not do well and you can prognostify and say they're not doing well. But more important to me, it's not prognostication. It's only prognostication doesn't matter. I think we are moving to an era where we say, does it predict? And we need prediction. So if we didn't get a good response, I think that's the space where we will talk about escalation of care in the adjuvant setting. Will it come to more chemo, different chemo, or immunotherapy? And I think it's going to be the immuno era that's going to take over. The disadvantage is you're not going to get an accurate staging.